Good morning, everybody, and welcome. Welcome to our second JBI Evidence-Based Healthcare Symposium, the JBI Solution Room. It's such a pleasure to be here with you all today. My name is Zachary Munn, and I'm the Director of Transfer Science at the Joanna Briggs Institute, and it's my pleasure to act as a chair of today's proceedings for this event. Now, before we get into this event, I would like to firstly acknowledge that today's event takes place on the traditional lands of the Kaurna people. And I wish to acknowledge the Kaurna people, the original custodians of the Adelaide Plains, and the land on which the University of Adelaide's campuses at North Terrace, Waite, Theberton and Roseworthy are built. Now, I'd also like to thank our major sponsors for today, SA Health, who we have partnered with for today's event and who without which this event would not have been possible. And particularly I'd like to thank Jenny Hurley for all her work in supporting this event as well. So, good morning. We are certainly in for a fantastic event here today in this beautiful building. Now, you have all come here today with questions, problems, and perhaps challenges that you have encountered when trying to get evidence into practice. You are all wanting to get evidence into practice, my kind of people, and we have heard these problems and we can empathise. And I can say to you today that you will hear some solutions to these challenges. Today is about finding out how we can do better, and our first keynote speaker for the day will talk about this. So, our first keynote is Professor Bridie Kent. Bridie is a world-renowned expert in knowledge translation and strategies to increase implementation of evidence-informed practice and policy. Bridie is a registered nurse with extensive experience in clinical and academic roles. She did work in New Zealand for some time as an academic until she saw the light and moved to Australia, of course. But you did get sick of Australia and our beautiful weather and moved to Plymouth in the UK, which is surprising. But I did find out this week that Plymouth is the second sunniest city in the UK. Okay, which doesn't really mean much, though, I guess. But okay, very good. In Plymouth, she keeps very busy, along with being the current Executive Dean of the Faculty of Health and Human Sciences at the University of Plymouth. She is also the Director of a Centre for Innovations in Health and Social Care, which just happens to be a JBI Centre of Excellence. Bridie has published over 180 peer-reviewed papers, and amongst all of this, she somehow manages to find time to train for and compete in marathons. And after some Google stalking, I found that you can complete a half marathon in about 2 hours and a full marathon in just over 4, which is just remarkable. So well done. Your talk shouldn't be as tiring as a marathon today. And we are very lucky to have you here with us. Please join me in welcoming Bridie to the stage.
Okay, brilliant. Thanks so much. Well, it's a real pleasure to be here, and I'm really glad that the weather's improved, because when I landed on Friday, I went into Melbourne, and we got the rain, the hail, the thunder, and my friends were really pleased, and I'm thinking, I'm not. I've just come out of winter. You know, I was looking for some decent stuff. So yeah, so it's you put it on today, so that's really good. So yeah, what I want to talk about today is really a few bits. It's a bit of a whiz tour on what evidence implementation is all about. I'm going to make the slides available because there's some useful linkages embedded in the presentation that hopefully you'll be able to take away with you and actually be able to utilise in the future. So it's very much of a resource that hopefully you can keep. I also have given you I'm going to talk about one particular model that probably doesn't get as much coverage within the health professions as or the health arena as certainly in Australia, and definitely didn't in New Zealand. But I think it's one that actually might resonate with you, and I thought, well, it's quite useful just to stretch your thoughts just a little bit further. So let's move on. I'm going to show you. This is a view from my office. So see, it is sunny. And so yeah, it's the view off the Hoe. So this is where Francis Drake saw the Armada coming. So there's some history there as well. This is the team that I work with. So we've got a very unique situation really in the southwest of England. We set up what we call professorial units. So we call them clinical schools, but it's not the best of terms. But basically we've got professors out in the clinical setting working with clinicians, really getting evidence implemented into practice. And by having that, those role models out in the clinical setting, we're really seeing some transformation taking place. And we're using the science of implementation to really transform healthcare within the settings for our populations, both in the acute services but also in the community primary care areas. Now I'm going to sort of take you back and think about, this is a quote from Jeremy Grimshaw in 2012, and it resonates with Jenny was saying around the fact that we've got a real problem here, and we've got to, we've got a group of you here who actually can make a difference. So consistently we've got lots of evidence, but we're not translating it, and the people who are affected are our patients. So they're the ones that are experiencing quite a lot of suffering, maybe harm, all sorts of things. The health organisations are also affected, because if we know that there's innovations that are out there that are effective and we're not putting that into practice, then there's often significant financial implications that can come from that. So we've got there's a lot of cost around this, and I think we as health professionals have got a responsibility to do something about it. So there is a challenge. It's to transfer what we know actually into action and get those innovations there that we know have got some proven effectiveness. We can keep going and doing research on research. There comes a point where you've actually got to say enough's enough. We've already got enough information. Actually, now we've got to get there and put things into practice. I sat on a big grant research body in the UK for several years, and we actually got to the point where we were saying if a grant application came in on a particular topic, we would just reject it straight out because there was already sufficient information. And it didn't really matter if we were looking at blue toenails or pink toenails. The toenails, was an element that we'd already cracked. So it's a real case to say, just because you haven't got something in your area of practice, look and see what the broader picture is, because generally we can, with some adaptation, we can translate that evidence. So coming back to the what of implementation, this is very much around the broader topics. It's been around for a while now. This is Carl May's interpretation from the UK, and one of the things to iterate is it's a process. It's not a moment in time, and yes, it does take it takes working on. It is it's something that you're going to have to address in multiple ways. But at the end of the day, it should be continuous. It should be interactive. What we've got at one point might then change when somebody else applies it. But actually, those are those learnings that we need to take on board. The science of implementation is around the methodology. It's around those tools that we can use. And by understanding what they are, we can hopefully then be able to understand them, take them on board, and be able to utilise them in a way that probably we haven't done before. And so Martin Eccles and Brian Mintman, who were the founding members of the journal Implementation Science, they came up with this definition to try to help people to understand just what are we talking about here. And it is definition that is a problem, and you'll see in a minute where things are starting to get very, very muddled, and we need to just come back and think, what is it are we trying to do? And we're simply trying to get the evidence that we know works translated into practice using some robust tools. Crucially, when we're dealing with all this, it's about behaviour change. You're not going to get practice change occurring if we don't have some change in behaviour, be that from the clinicians or from the patients or from both. And so when we're starting to look at the theories, the frameworks around implementation, it's looking and seeing what do we need to do to really push that behaviour, to what are the triggers around, what are the blockages, what are the things that enable that change to take place. And let's put it into into understand some of the science behind it, because then that helps that robustness of the process. So it's around a set of tools that you can use as a bit of as a collection that it doesn't all have to be done, but you've got a toolkit that you can draw from, and that I think is really, really useful, because some work better in some circumstances than others. But it's really, you know, what we're trying to achieve is this adoption of new practices. Now, some of the confusions come over the years because the word terminology's changed. So we've had research, so in the early stages, around about the 1990s, in that decade there, we had research utilisation. And it really sort of focused in on the fact that this was all about empirical studies. It shifted a bit, just like my slides have. They haven't quite worked, it doesn't quite work out. It got lost in translation. So when we moved into the next decade, it got broader, and we've seen it with JBI, you know, the tools that JBI have adopted. You know, we've moved from evidence-based medicine very much to evidence-based practice. It's a much broader concept. Then the work from Canada started coming in around knowledge translation, knowledge utilisation. And then there was a knowledge exchange, which is right down at the bottom that sort of dropped off a bit. The next decade, terminology was starting to change again. And obviously you know, we're coming to the end of this, so I'm not quite sure what we're going to end up in the 2020s, but hey, anything's possible. But what we started to see was a much more of an active process, this mobilisation, this, instead of it just saying we need to translate things, it's actually let's mobilise this knowledge, let's make it a really interactive and positive process. And implementation science was one of the elements that came in at this time. This was a slide from the US, which showed again some of the terminologies that are out there, with different entities adopting slightly different slants, slightly different interpretations. Ultimately, though, we're trying to get the evidence there to ensure that the right things are occurring. And just to complicate matters further, in the UK, what we're seeing through is improvement science coming forward. And so we've got clinicians thinking, what the hell have we, you know, what is this all about? So organisations such as the Health Foundation are really advocating the term improvement science. And it's all about trying to make things perhaps a bit more approachable, a bit more understandable around the processes for change and that transformation that takes place. For me, the key difference is probably in scale. So when I look at implementation science, you look at the studies that are coming out and the big changes that are taking place and how that contributes to that body, moving forward, that body of science. You're wanting larger scale studies, so maybe multiple centres. It's not just a small scale improvement project. The improvement science, though, is really recognising that actually in different health services, you need those improvements to take place. And let's utilise some of those tools. Don't knock them. You know, don't sort of say, actually, because it's a small scale, it doesn't contribute. Yes, it does in its own way. It contributes really significantly. And if that's the scale of the project that's needed to get that knowledge translated into your organisation and get that practice change cascaded throughout and beyond, go for it. I think it's really important. They're not exclusive. You know, I think we need to recognise that. There's also some elements, particularly in the UK, and to some extent here, around the practicalities of getting an implementation study versus an improvement study into practice. And if we're looking at ethics approval, improvement studies tend to be low risk, so it's sped through the ethics process quicker. In the UK, we can, if it's classified as an improvement or service improvement study, it doesn't always have to go through our very long-winded NHS ethics process. And actually that's advantageous. We've still got to look at the safeguarding of people. You know, it's really important to keep those principles there, but it doesn't necessarily have to go through the same lengthy processes. So I think what we're seeing now is this move very much towards the right of the screen, where we've got improvement knowledge, and it's that continual improvement. It's looking to see, let's make incremental change, let's learn from that, let's see what we're doing, and rather than say that I see it time and time again in the National Health Service in the UK, where people have come in with some really good ideas, they've implemented something, it hasn't worked, so they've just gone, okay, we'll just move on. We've not actually had a look to see what on earth, what is it that hasn't worked? And I think we can learn an awful lot from that process. So, there's elements that, do work. I'm involved in a project at the moment, a big scaling up project, and it worked in the smaller scale. We've now got funding to extend it out, and we're seeing that in some areas we've got some problems. But it's not the innovation that's the problem. It's the people that are linking in, and it's how do we understand the system and modify the system, get that behaviour change taking place to actually get this innovation working well in that setting. And understanding that takes time. This is a really nice paper from Rebecca Miltner, who works very closely in the US with Brian Mittman, and it's talking about the definitions around quality improvement, improvement science and implementation, and that the fact that there's lack of consensus around the definition really creates some tension. And there's, she works very much with the Veterans Association in the US, and they've had a big quality improvement program going for a long, long time. And, and I think it's worthwhile understanding some of the learnings that come from there. And if they're saying that actually we really need to closely define this, then I think JBI have got a really good role to play in this and define through their implementation group. Really, let's clearly get this nutted out. Let's really get it clear what it is we're talking about and really lead on that, because I think it'd be really worthwhile. We need better dissemination. We need to get the information out there. I'm not sure about how many of you have been involved in projects, whether they're small projects or not, and then they've never got written up or they've never got disseminated, and you think, come off it. How many times have you gone to conferences and think, and somebody's out there spouting forth, and you think, blooming, I've done that. I've already done that, and it's really annoying. Well, use the skill. You've got some amazing support here in South Australia. Utilise it and get that information out there. Show the world what's going on here. So we do. It's not just about peer-reviewed publications, but they help. We've got tools that are there. Let's go and let's utilise every resource that we can, and make use of social media really to communicate these changes that are occurring. I've just been doing an editorial for Ed's journal, and it started me thinking about these elements of innovation that where you've got that hair really takes off, and one of them was NPJ paralysis. Now in the UK, if you look for an evidence base, there isn't one. There are no published papers that I could find recently on PJ paralysis, but certainly in the UK and other parts of the world. It's been a movement that has transformed patient care. And yes, we've had to do some behaviour change on both sides, from the clinicians and the patients. But actually, let's get people up and dressed. Let's get them moving. They shouldn't just be sitting there by a bed just because they're in hospital. Let's do let's get that activity going. And that is one example where it was led by a nurse, and it has really transformed care. Both in many different parts of the world. So some of the questions, let's come back to some of the science here. This is Jeremy Grimshaw again saying, okay, right, what are the key questions? We need to look at what should be transferred. We shouldn't be transferring everything. There's some things that are more important than others. Let's look at the strategy. Let's go for what is the strategy for health that we're really wanting to promote, get the evidence there and focus attention on that. Because otherwise, if we try to spread ourselves too thinly, nothing actually gets done. So think about what needs to be transferred. Who are you transferring things to? Who are the people that are doing the transferring? And these are people, like yourselves. Let's empower people. Let's say, come on, yep, we can do this. Look at the how. Understand what are the ways that have been proven to work and what doesn't work. So education alone, we know, does not work. Education in conjunction with other things is okay. So all of these in-service education sessions that we're really keen to deliver, be really careful on those, because they go in, they go out, and they don't actually get the information retained in many cases. So think about what other strategies need to go in place alongside them. And think about what's the effect, what are we wanting to achieve here? Is it small-scale effect? Is it a large-scale effect? Either are fine, but let's get some agreement on what that achievement's going to be. So I'm just going to very much whiz through, I know I'm running over time, so I'm going to whiz through some of the theories here that are out there. You've got three main groups, and it's not sleep time. I'm not going to go through all of these, but they're all about, it's motivational. They're either action theories or they tend to be organisational. It all depends on the type of approach that you want to take. There are tools that are out there now to help you work out what's the best approach. I'm not going to go through this framework, but again, it's here that Cheryl Stetler from the US developed this, and it's actually quite a nice one just to work, to go through. Ultimately, though, it's what's that fit. So the choice is around what it is that you want to do, the people that you want to do that with, which isn't, my grammar's not particularly good, and and trying to get that alignment going, because you've got a choice. There's a number of different theories or models or frameworks that you can use. Find one that you like, that you can understand, and you can then drive forward. The one I'm going to look at today is one that probably is less well known in certain settings, and that's Susan Mickey's theoretical domains framework. It sounds really wordy, but actually when you start to unpick it, I've got a PhD student of mine at the moment who I've directed her to this, and I said, if you look at what you're doing, you'll suddenly get an aha moment, because you'll read this and think, yeah, that really closely aligns. And certainly she said, yes, it's coming, so that's good. It was developed using a very sound methodological process of expert consensus. So a group of people got together and very much looked to see what were the things that were needed to go in there. It was originally came up with a set of 12 indicators, a set of 12 domains, and that's been expanded out to 14. I've got them on the next slide for you. But you can use them in different ways. So they can be used to help guide interview questions, around guide questionnaires, just help that inquiry side of things. But it's also quite useful to use as a tool to match against when you're wanting to do the analysis. I've used it when I was in Melbourne, trying to develop a new IT system, and trying to get that very much from the ground up rather than being imposed by developers. And it worked really well to help us understand what were the enablers and what were the barriers. These are the 14 domains. They're very wide-reaching. They cover, and there's subdomains that fall within these. So again, it's a tool that you do need to have a look at and read. So these are the links to the subdomains. So by all means, use this, have a click on it, and it'll explode. You'll be able to see what all of these are. It's been very much informed by this COM-B model, and again, there's a link to this in a PDF. And this is what the COM-B model's all about. So it's looking at capability, it's looking at behaviour, and it's looking at motivation. So there's lots of different things elements within that. The behaviour change wheel that's over on that right side, is that the right? Yeah, it's the right side for you. Then that shows you how it works with the theoretical domains framework, and you can see the different segments of the wheel that really help to you can look at and target to get that change occurring. It's been used in a number of ways. There's a package of papers within implementation science that's on open access that you can get hold of, but they've been used for things of small scale and large scale, including this one here looking at traumatic brain injury, helping to understand what were the recommended practices and how can we embed those into practice. And so it helps to identify quite quickly what the barriers are and the enablers are, so that you can actually get that behaviour change occurring. The other area that we need to start focusing on is around clinical significance. So rather than looking at the statistical significance of interventions, let's have a look at the clinical significance. Let's understand what those are and use those things to drive that practice change. Because if you're looking at how do we convince people about what we do, p-values aren't going to sell it. Clinical significance can do, because people can really understand then what does all this mean. We've got to look at context. We've got to understand the settings in which change is taking place, and it's crucial that we do that. And we've also got to look at how we transform this information into useful forms. So we need to have information here that is going to really be accessible, be well utilised from the clinician's point of view, but also from that service user point of view. You know, let's get them very much active players in this process as well. They're not being done to, they're being very much, this is co-production. We're seeing funding slowly changing for this, and I'm really pleased to see this. In the US, we're seeing changes. I'm seeing changes in the UK. There's also been changes with NH and MRC around implementation. And that's, instead of it being an add-on, it's really being seen as a useful way of getting change occurring. So for us, we need to embrace that change. We need to look at the evidence to inform practice. We've got to accept that and recognise that underutilisation of evidence is there, and we've got something to do with that. We can make a difference. And each of us really have a responsibility to really offer our service users that best care and actively do something about this. So I'm going to leave you with this quote around, the power of dreams. We can dream to achieve all of this. It's not something that is, it's not out of our reach. There's some effort that we've got to do, but I think it's worth it in the end.